Now, obviously I can't teach you how to manage your patients on a video, but what we can do is look at a few principles that hopefully will increase our level of understanding of how we intervene to benefit our patients if they're suffering from an acute coronary syndrome. And the first thing to say, the mantra that we should memorize if we're working in this field, is time is muscle. The longer we delay, the more the coronary arterial occlusion will have to result in myocardial necrosis. The bigger the infarction will be. So the quicker we can intervene, the more myocardium we can save. For all the time that we delay, all the time we're delaying, more and more myocardial cells will be dying, and the myocardium does not have significant powers of mitotic regeneration. Once those cells are dead, that's it, they're gone, they won't be replaced. Now they will heal up, the myocardial infarction will heal up with fibrous scar tissue. That's good, it will stop it leaking. It'll maintain the overall integrity of the myocardium, but of course the scar tissue will never be contractile. There will be permanent reduction in myocardial contractility. The heart will never work as well again. Time is muscle. Intervene quickly, stop the muscle dying, preserve the integrity of the myocardium. Now we're going to try an ABCDE approach here to help us remember what we're talking about. A is for access. We must have good intravenous access. It must be safe and it must be reliable. We can take bloods from it, that's good for our troponins and things, another test that we want to do, but then we flush it through and we must maintain good quality, safe IV access. Because the patient may require further drugs and they may require emergency resuscitation, necessitating emergency drugs. And the reliability of that IV access can determine the outcome of that treatment. The quality of the IV access and the reliability of the IV access can actually make the difference between life and death. So we've got to have good, secured IV access. The next A is for assess. So we're going to assess the clinical picture that the patient has come in with, and we're assuming that they are presenting as an acute coronary syndrome. Then we need to assess with bloods, but they're going to take a few hours to come back. Now it does depend how sensitive your troponin machine is, but it could easily take 2 or 3 hours before we get our blood results back. So we can't wait for that. So we have to assess on the clinical picture that we see, and we have to assess on the 12-lead ECG. So these patients need an emergency evaluation of their ECG using the 12-lead ECG technique. Now, if the patient's suffering from unstable angina or non-ST elevation myocardial infarction, the STs could be normal, or sometimes they might show some ischemic changes with ST depression. However, if the patient's suffering from a STEMI, an ST elevation myocardial infarction, then there will be ST elevation, or there might be new left bundle branch block. So in a few rare cases you might not get ST elevation, but you do get new left bundle branch block. We count that as a STEMI. But in most STEMIs you will get exactly what it says, ST elevation myocardial infarction. And that's very important to know about, because all of these patients are going to need the basic treatment for acute coronary syndrome. But if there's a STEMI, they're going to need PCI, or they're going to need intravenous thrombolytic therapy as an emergency measure. So first one is access, next one is assess. The next one is antithrombotic therapy. We want to reduce the thrombosis getting any bigger. So A can be for antithrombotic, A can also be for antiplatelet. And that's the first thing we do. We can give aspirin, maybe a loading dose of 300 milligrams, and then followed by 75 milligrams a day. And we can give clopidogrel as well. Aspirin and clopidogrel given together work particularly well. Very often the loading dose of clopidogrel will be 300 milligrams. But if the patient's going to go for PCI, then they should have had at least 600 milligrams of clopidogrel. The reason being that PCI is going to blow up and disrupt the atheromatous plaques. And the core of the atheromatous plaques is thrombogenic. So during coronary artery revascularization therapy, using PCI, percutaneous coronary intervention, there can be disruption of the atheromatous plaque, meaning that thrombogenic material from inside the plaque comes into contact with the blood, giving rise to the possibility of iatrogenic, that is treatment-induced, renewed coronary arterial thrombosis. And we don't want that. So the patient should have had at least 600 milligrams of clopidogrel prior to the procedure. A can also stand for aspirin, of course, A, which handily begins with A as well. A is also for anticoagulants, like heparin and fondaparinux. So heparin and fondaparinux are both anticoagulants. They will stop the blood coagulating, and if there's any red thrombus there, as you would get in an ST elevation myocardial infarction, they will stop that getting bigger. If there's no red thrombus there, as you would expect in unstable angina, as you would expect in non-ST elevation myocardial infarction, where the thrombus is primarily the white platelet aggregated thrombus, then giving anticoagulants can stop that thrombus from developing in the first place, preventing an increase in severity from a non-ST elevation myocardial infarction to an ST elevation myocardial infarction. We can prevent that, or hopefully prevent that, with anticoagulants. So that's the A's. We've got assess, access, antithrombotic, antiplatelet aspirin, anticoagulants. They're the A's. Now the B is for bed rest and beta blockers. Now, if the oxygen supply to the myocardium is compromised, there's a reduction in the blood supply to the myocardium. What we don't want to do is have the patient exercise, because that will increase the metabolic demands of the myocardium. And exercise can also increase the possibility of arrhythmias or dysrhythmias developing, such as ventricular fibrillation or ventricular tachycardia and various other things that we really don't want to see. So we put these patients on bed rest, we get them to rest. And not only do we get them to rest, we want to reduce the sympathetic activity that's going on inside that patient's body. And one of the major drivers of sympathetic activity is anxiety. So anything you can do to calm the patient down, to reduce their anxiety, is good and can actually increase their probability of survival. So B for bed rest, to reduce myocardial oxygen demand. And beta blockers, very often given intravenously, are good for ongoing ischemia. They relieve pain because they reduce myocardial oxygen demand and therefore reduce the probability of anaerobic metabolism. They also make dysrhythmias, as we've mentioned, like ventricular fibrillation, ventricular tachycardia, less likely, because they're reducing the excitability of the myocardium, which is good. And we know from fairly large-scale epidemiological studies that if beta blockers are given within the first 12 hours after an infarction, that's associated with reduced short-term mortality. So that's good. So B, bed rest, beta blockers. That brings us on to C. C stands for coronary arterial vasodilators. So GTN, glycerine trinitrate, given sublingually, is very often useful. Now GTN can work very well in stable angina, but it can also give the patient some benefit in unstable angina and even in non-ST elevation or ST elevation myocardial infarction. And indeed, sometimes if there's ongoing ischemia, we can give intravenous infusions of nitrates, because the idea is that the nitrates will vasodilate the coronary arterial system, maximizing the perfusion of the myocardium. So C for coronary arterial vasodilators. D in this ABCD is for diamorphine. Morphine sulfate or diamorphine is indicated for myocardial pain. This is one of the worst pains that we see in medical patients. The patients are in intolerable, heavy, crushing, central, radiating chest pain. An appalling, agonizing, distressing, terrifying pain. And we need to treat it aggressively. And diamorphine is a very effective treatment for that. Normally would titrate in 2.5 to 5 milligrams and give an antiemetic as well. Morphine we might use 5 to 10 milligrams, again titrated. But use opioid analgesics for these patients for the pain. And the other advantage of morphine and diamorphine is they are very anxiolytic. They can reduce the patient's anxiety levels. That's going to reduce their sympathetic activity. That's going to reduce the excitability of the myocardium and probably make arrhythmias, dysrhythmias, VF, VT less likely again. So diamorphine is the D. Now E is for enough. The patients probably have enough oxygen already. Now the reason we've put this one in is because for years and years on coronary care we'd get a patient in and immediately put them on oxygen. But in actual fact we don't need to do this. If the saturations are 94% or above, we don't need to give the patient additional oxygen. Now if the saturations are below 94%, then yes, please do give the patient additional oxygen. Bear in mind the possibility of COPD and CO2 retainers of course, and treat those as we normally would. But patients need oxygen put up to that level. If it's below that level, the myocardium can be more hypoxic and will benefit from oxygen therapy. But if the oxygen therapy puts the oxygen saturations up to 99 or 100, the idea there is it's going to increase oxygen byproducts such as free radicals. And free radicals can damage the myocardium, possibly making the infarction worse. So if the SATs are 94 or 95%, we're happy with that. If they're less than 94%, do give some additional oxygen. But E is most patients already have enough oxygen. And that's the basic principles of treatment for acute coronary syndrome. Now, if the 12-lead ECG showed that the patient had ST elevation myocardial infarction, that they had a STEMI, then we need to get that blood clot out as quickly as we can so we can reperfuse the myocardium. They need reperfusional therapy. And the best way to do this is PCI, percutaneous coronary intervention in the catheter lab, where we can actually suck out this offending thrombotic red blood clot that's caused the ST elevation myocardial infarction by infarcting a significant area of the myocardium, completely depriving it of its blood supply. If we get the thrombosis out quickly, then the myocardium can recover, virtually completely recover, as long as we get this done early. Time is muscle, it needs to be done quickly. If PCI is not available, or if PCI will be delayed for a period of time, then we need to give intravenous thrombolysis, drugs which break down the fibrin strands, holding the blood clot together, chemically dissolving the blood clot, again hoping that that allows for myocardial reperfusion. And indeed it does. But if you have the choice between the two, if you can give PCI or you can give thrombolysis in the same period of time, then we definitely want to go for the PCI because we know that's associated with an improved prognosis for our patients.